Hello, friends. Joe D'Amato's here in Maryland from the Health Facilities Association of Maryland. Welcome to this State of Reform session, how COVID has changed our healthcare system. We are so fortunate today to be joined by two physician leaders for this conversation. We are joined, let me just give you a minute on each. First, we're joined by Daryl in Michigan. Daryl is the president of his healthcare system. He grew up in LA, so he's got a lot to celebrate right now. He did his undergraduate work at UCLA. He did his medical training at Michigan and his residency at the University of San Francisco. We're also joined by Dr. Josh Green, the Lieutenant Governor of the great state of Hawaii. Dr. Green, Josh, did his undergraduate training at Swarthmore, studied at Penn State for his medical training, and was a representative and a state senator and is now lieutenant governor. So Josh, if I may, I turn the floor over to you.
Thank you, Joe. I really appreciate it. I'm going to speak a little bit about Hawaii's experience through COVID and then perhaps dive into some of the concerns I have. And it's a great honor to be on this panel with you, Joe, and you, Daryl. It's terrific. So I came to Hawaii a long time ago with the National Health Corps. Actually, I'm a family physician by training, although I work ER now. I'm on call this weekend, still doing 1 or 2 shifts a month, just because we have a healthcare shortage, and it helps keep me somewhat grounded and in touch with what goes on outside of politics. And so throughout the COVID pandemic, I've been seeing it from both sides a little bit. I've been seeing it from the policy side, and Hawaii has wrestled like every other state with COVID and its enormous impacts. And then clinically in the countryside, where we often have a serious shortage of resources. We have a very rural state. We have a 22% shortage on healthcare providers globally, if you just look at the population, but we have a 40% shortage if you look at the neighbor islands like Big Island, Maui, Kauai, and so on. So we have challenges, and so that's the perspective that I've been kind of looking at it through. Hawaii has been lucky in some ways with COVID, and maybe we made some of our own luck. We've had the second lowest case rate and the second lowest mortality rate. Second lowest case rate behind Maine, and second lowest mortality rate behind Vermont, I believe. And we had to take some very serious actions in order to control COVID, which will also inform what the impacts were, because it's a double-edged sword. So when I first saw COVID coming, actually I was acting governor. The governor was traveling in Japan of all places, and we had our challenges because, number one, we see a lot of travelers. We average about 10 million visitors a year for a population of only 1.4 million people. So we expected a global pandemic to really roll up on our shores quite impactfully. And that first week when I was on duty for the Gov, we actually had a traveler, believe it or not, from Wuhan, who had traveled from Wuhan, I think, to Shanghai and then to Japan and then to here. And he did not end up being positive, but we put him in quarantine back in February for 2 weeks in an army barracks because we just didn't know. And that's, I think, one of the stories of this pandemic. We didn't know a lot in the early days, and we know a lot more. But that was extraordinary. And when we then contemplated what it would mean to have travelers from New York and California and all across the United States and Canada and Europe, and of course Asia, where we get about 15% of all of our travelers come from Japan. Another hunk of people come from China and Australia and so on, but much of our economic opportunity from those individuals, we knew it was going to be tough. And so what we did was we shut down totally. I don't know if people recall this, back around the 3rd week of March, we shut it down. We totally curtailed all travel into Hawaii. We dropped travel by 99.6%, which means that we zeroed out our economic capacity, and we protected ourselves from the unknown. We just truly didn't know how many cases would come. So what happened for us is we had a multimodal experience with COVID. We went from low cases to no cases. We literally were having an average of 1 case a day at one point over 30 days, like no cases to discern. But we didn't have a functional Department of Health, public health response yet. We didn't have testing set up. We didn't obviously have any vaccinations yet, because they didn't exist. And we didn't have even a contact tracing system in place yet. So when we finally decided to contemplate opening up, the cases surged. And what we we saw was they surged on the mainland and then they come here, just like the flu comes later. We were always behind a little bit. So we were forced to devise a plan to open up safely. We called it Safe Travels. And we almost called it Safe Hawaii Travels, but the acronym was not appealing. So we scuttled that before that got launched. And we reviewed where we were. We had a big surge after the surge on the mainland. We then had a surge after July 4th, and it was impactful, of course. Ultimately, we put the Safe Travels program in place, which meant that you had to be pre-tested within 72 hours of traveling here. Not perfect, right? But it provided, and this was with the nucleic acid amplification test, PCR test, it provided a lot of thoughtful cover for us, and people had to go through a process. Am I going to travel far away and risk being in quarantine otherwise if I don't do this? And spend a lot of resource, personal financial resource. And so that worked. I mean, we were able to open up and restore our economy. So we went from 2% unemployment and no cases to still no cases, but like 25% unemployment, total economic devastation, which has its impacts. And then we opened up and we ended up having modest cases, but we're able to manage it. And we brought back 70% of our travelers. So we had 7 million travelers over the course of the year and survived. But it was very challenging because you can imagine from a policy standpoint as Lieutenant Governor, I was tasked to kind of run much of the response with our General Hara. It was shocking to see the ups and downs for people. We are grateful that we've had so many fewer fatalities. We had projected 4,479 fatalities a year. And so therefore 9,000 over the 2 years. Instead, we've had 1,274 fatalities. So we're down about 85 to 90%. Our positivity rate's always been 3 or 4% below national averages. And like I said, we've had low case counts. And the other things I would comment on about our experience was that we have finite healthcare facilities, as I mentioned before, and not just beds, but staff. And eventually they all caught Omicron. Myself, I actually caught the original variant in September of 2020. Was just sick for 2 days. I was lucky. My dear friend from Swarthmore died at age 51. He was a marathoner. Like, I think, Joe, you're a marathoner, I think, right? And so very good shape like you, and he didn't make it. It's unbelievable. With no underlying health conditions, by the way. So we wrote it up and wrote it down. And then we peaked at 448 people in the hospital at one point, which for a small state like us, we were at like 97% capacity before we were going to have to engage in some questions that we did not want to engage on, like crisis standards of care and i.e. rationing care. We then started spending money and had FEMA support to bring in hundreds of extra nurses and respiratory therapists, and that worked. We came down off of that first peak. At that point, 4% of all of our cases were hospitalized. That was the Delta peak. And then later we ended up having an Omicron peak, but that peak was lower. We had 393 cases at a peak, and that was out of 58,000 active cases. First one was 448 people in the hospital out of 11,000. So that was 4%. The second peak was much lower, 393 people in the hospital out of 58,000, which was 0.7%. And so I watched the numbers day in, day out, every single hospital where we needed to have an infectious disease specialist or a team. So we used a lot of analytics to study these things. And that's how I think we were able to constantly deploy resources and keep cases very low and make decisions that were survivable for society, but very helpful for our kupuna, the name we use for our elderly. So that's what our experience was, and then we could unpack more of that later. And then just maybe a 90-second version of what I worry about before turning it over to Daryl and you, Joe. I worry about long COVID. Obviously, we've had 200,000 or 300,000 people that have had COVID, so we don't know yet what that impact's going to be in a small state with a relatively limited capacity to deliver healthcare. I worried about delayed care a lot. We definitely, in my experience, I'm in the ER. I'm not a family doctor any longer, but I know a lot of people didn't get colonoscopies, didn't get mammograms, didn't go for their refills for their diabetic medications. So that's a concern. And my biggest concerns, I would say, are the behavioral health concerns. We saw a big surge in self-harm. We saw a big surge in addiction. There's a lot of isolation and addiction in Hawaii, and that has always been a problem. The opioid epidemic has been minimized in Hawaii because we don't prescribe a lot of opioids compared to most states, but there is a fair amount of self-harm and illegal drug use. And then The trauma and despair, the economic trauma and despair has, I think, worsened our healthcare disparities and our social health considerations. And those are real concerns for me as a lieutenant governor. And I'm not bashful about it. I mean, I'm running for governor right now. And so if I do well with the people of Hawaii, and they did respond very well to my team's effort, which we're grateful for. I know that I'll inherit those challenges as just a person who worries about things and worries about people. So that was our experience. And I actually want to then now defer to you gentlemen, because I'm so excited to hear what you've experienced and what you think about healthcare after COVID.
Mahalo, Josh. That was a great unpacking. Daryl, we'd love to hear from you.
Great. And let's see, I actually have slides. Are you able to see these?
I see them. Awesome. Well done. And I want to remind people that they can post Q&A. They just click on the Q&A and they can post questions there.
Great. So it might be helpful. I'm obviously going to have a little different frame of reference as opposed to talking about leading a state, which Hawaii had done a masterful job. I'll talk about the experience here in the state of Michigan from the perspective of a large healthcare system and how I believe it's changed our healthcare system and will change healthcare in the country for years to come. And so just a very brief description of where I'm from. I'm actually standing in Grand Rapids, Michigan with a little bit of snow. I'm part of Spectrum Health. I help lead Spectrum Health, which actually as of the beginning of February is now a much larger system because we merged with a system on the east side of the state called Beaumont Health. So we're now far and away the largest health system in the state. The purview I'm talking about and what I've led for a number of years is 11 hospitals and a very large physician practice and so forth. And we are far and away the largest health system on the west side of the state before. And so this describes our experience. And so I actually gave a talk really the beginning of 2021, talking about the lessons that we learned from 2020, the beginning of the pandemic, really. And remember, that was a time when we all thought this was going to be over. Vaccines were just introduced. We were so hopeful that, we can get in the spring, things would be better. And I had a top 10 list that I remember presenting at the time that talked about this. And my number one was frequent and transparent communication is key. And the reason for that within our health system and within our community was, as Josh described, there were so many unknowns so early, so much fear, so much panic, that our goal all along was to be transparent and describe data and describe our experience for the community and for our 31,000 at the time team members. And so fast forward a year, and I actually just gave another talk talking about what we learned going into 2021. And I had the exact same 10 learnings, but I reordered them. So while I still absolutely believe that frequent and transparent communication is key, the number one lesson learned was that our most limited resource are our people. And I think you'll hear a theme from me today, particularly when it comes to healthcare. There's a lot automated in our world now. You can go online and do Open Table and make a restaurant reservation. You can do so many things on your phone. Virtual care is here, but nonetheless, delivering care to a population requires a lot of highly skilled people. And when you don't have enough people, that often is the limited resource. Early on in the pandemic, I remember sitting in our control center talking about how many ventilators we can order when the projections were we'd need thousands alone as a health system, to this last year where all we talked about was how are we going to take care of our population with not enough nurses, not enough respiratory therapists, and so forth. Let me move on here. And so I talk more about our people, and I can say that in healthcare, there was an impending explosion or implosion, however you want to look at it, that was coming from a mile away, and COVID just exacerbated it. It's almost like the supply chain we talk about. When you look at nursing, when you look at physicians and other skilled specialties, we have not grown the pipeline for years the way we needed to. And we have many, many people in healthcare that were on the verge of retirement, that this accelerated their retirement, or quite honestly, and I just heard the other day about a young nurse that came in and so overwhelmed by what she's seeing in healthcare now that she rethought her career path and resigned. And so the problem we face now is somewhat of our own making that COVID exacerbated, but as a country, we're going to have to figure out how we expand the pipeline and get more people into healthcare, or we're all going to be in trouble. As we start losing our hair and getting a little more gray, we're going to be the ones that need it pretty soon. And so I'm going to talk specifically about what COVID's done to healthcare workers. This was a study early on. I'm sure all of these bars are actually further over to the right now. And essentially, and this was in 2020, what are the top three stressors? Uncertainty about when get back to normal, experiencing stress, anxiety, frustration, physical exhaustion, trouble sleeping. These are signs of anxiety and depression that essentially all of our healthcare workforce has experienced throughout COVID. And quite honestly, this was after surge number one. We just completed our fourth surge, which was far and away our worst. It was Delta going into Omicron. And just in the 11 hospitals that we had on the west side of the state, when I was listening to Josh about Hawaii, we actually peaked at 503 patients, including about 140 in an ICU. Numbers that were mind-numbing. We converted areas that never were meant for patient care into patient care to satisfy the demand. And something else that I know you've been watching the news and hearing about in the airline industry that people probably aren't quite as aware is rampant within healthcare, and that is workplace violence directed towards healthcare workers. I'm sure Josh sees this in the ED. We see it all throughout our system. Patients angry, upset, frustrated with what's going on in their world, surely, and unfortunately, very often taking it out on our healthcare workforce, screaming at nurses, hitting doctors, biting. We've had a broken arm. The list goes on and on and on. And then you add a lot of the kind of very hot button issues like masking, which we require, as does every hospital in the state of Michigan, for everyone to be masked coming in. And you can imagine the amount of angst that's causing. And quite honestly, a lot of folks say, why would I take this anymore? Why would I want to take care of people when they're yelling at me? And so the great resignation that I'm sure everybody is feeling in nearly every industry is happening in droves here. I'll show some data within healthcare, and I'm absolutely positive, because I have a large network across the country where we talk about these things, that what we've experienced here at Spectrum Health, just about every healthcare industry company has experienced as well. And so this is us. I told you that we have 31,000 employees before this merger. As of April of 2021, we saw a 32.5% increase in open positions. And as of last week, we had 3,240 open positions. That is 10% of our overall workforce. And if you look where that's mostly, aside from areas like environmental service and nutrition services, so the folks that help care for our facilities, the folks that help keep our rooms clean for patients, the folks that help feed our patients, it is in nursing, it is in respiratory therapy, where we have seen resignations and people leaving for high-paying traveling jobs that there's no way anyone could truly afford to pay for long-term, has really devastated the industry. And so going forward, what are we going to do as a healthcare industry? Well, the first thing that probably you've seen on the news, and we've done too, is invest more in compensation. Wages across the country stagnated for a long time, and we invested well over $100 million toward the end of last year to try to right-size wages off of our annual cycle and try to provide all sorts of different resources for our team members. But it's more than that. Data is key when you look at your teams, particularly when your teams are that large. Flexible work-life balance is key. We have folks that say, hey, I'd love to work for you, but I need to leave at 4 because I need to go pick up my kids. We're a 24/7 business on the inpatient world, and that's really hard. We have to learn to be flexible. We have to learn to really focus on a diverse workforce, and this has been proven over and over again, not only to help a company survive and thrive, but actually in healthcare, if you have physicians or nurses that have similar nationality or background or race of patients, they actually deliver better care, more trusted care from patients. So we have to think differently, do differently, and quite honestly, in a lot of our support areas behind the scenes, like information services, HR, we're now looking across the country for talent and having them work remotely, just like I'm sure IBM, Apple, and other virtual companies are. And so another lesson learned, and I would say, quite honestly, just like I said with the workforce, this is something we all knew was there, but has been highlighted. And this is a study actually pre-pandemic showing disparity in influenza vaccination rates among different races, showing pretty significant disparity with people of color having markedly lower vaccination rates than Caucasians or Asians. Well, you start looking at the COVID vaccine and forgetting the politicization of vaccine distribution, there are clearly disparities. These disparities partially may be access, but very often are different cultural beliefs or different ways of receiving information. You can look at the upper right corner there, and that was a study looking across every single state, disparities of the overall population vaccination rate and African Americans. And you can see below the little green little arrows, every single state had a disparity. And then you look in the bottom right, and this is not just based on race. This is also based on socioeconomic status. And you can see that people with higher income are vaccinated more across our country. So these are problems we've had that have led to health disparities across the way that we have to work on. And this is probably, I would argue, my saddest slide, which is I think we've all aware now that US life expectancy, all told, has gone down. And that is something that for decades only improved with the advent of modern medicine, sanitation, and so forth. It's gone down. And of course, there's a disparity there as well. You can see that for Blacks, disparity of 2.9 years compared to 1.5 years for the overall population, and Hispanics even a little more at 3 years. This is a trend that we cannot allow to continue and is going to require all of our efforts to improve. And so how are we going to do this? Well, I don't profess to have all the answers, but I can tell you one of the things that's key that we realized is you have to have data on the people you care for, the people in our population, so you can target folks to do better for them. So we looked at our data because we implemented with our electronic health record about 4 years ago a pretty big effort to try to collect data on folks. And unfortunately, what we realized, we overcomplicated it. We gave our check-in folks 125 different options for race, nationality, so forth. And it became so overwhelming to them, they didn't even know how to ask the questions, that they often would put other blank or put something in that they thought was appropriate. We have to focus on the social determinants of health, and I could probably spend 5 hours talking about why I believe that capitated care and value-based care is the only way we'll get there. Right now, it's much easier and you get paid a lot more to fix a total hip than to give someone physical therapy early on and prevent them from ever needing that. As I commented before, we have to focus on a diverse workforce, and we have to focus on new solutions and look up, not look down, look forward, not look back. And so I will close by saying that I think healthcare is changed forever. Josh brought up things like long COVID and all the problems we'll see, but I think we have to rethink how we deliver care. We will have to focus on our values. We will have to focus on communicating. We'll have to focus on getting better, because healthcare in the US right now, after 2 years of pandemic, is on the ropes. So with that, I will turn it over to Joe.
Daryl, thank you so much. That was incredibly thoughtful and data rich. And it reminds me on why I feel very fortunate to be on a panel with the two of you as physician leaders. And I'll tell you why, just explicitly. So I'm the CEO and president of the Health Facilities Association of Maryland. It's a non-for-profit trade association that's been around for 75 years. I've been here for 12. And we represent the vast majority of skilled nursing and rehab centers in Maryland, what are normally called nursing homes, and several dozen assisted living centers. And I'm actually pretty proud of something that we did on January 29th, 2020. But I have to do a shout out and tell you why we're proud of it. And that is that we actually issued our first HFAM COVID update on January 29th, 2020. And it was benign. It was the CDC's alert. Hey, there's this thing happening in China. It's not here yet, but we should probably be tracking on it. And the reason we did that, though, is because physician leaders such as you told us and said, hey, we got to keep an eye on this thing. And I'll never forget it. I'll never forget that we issued our first alert on January 29th. And then February, Josh, I spent a bunch of February actually following very closely two communities, Hawaii and Kirkland, Washington. And so then by the time that we got together in person in DC with Maryland Governor Hogan, was on March 5th. He was there for a multi-state governors gathering. And by the time that we got together on March 5th, we knew we were up to something that was going to be really historical and really challenging. It was the same day that in Maryland, our governor declared our state of emergency, March 5th. We then got together again and just such, it's neat. It's important to remember these key days and all of the people they represent, and put a face to all of these things. On March 10th, we had our first substantive meeting with the governor, and we had our first sort of plan of attack. Now, here's something that's really interesting for the listeners and viewers and each of you. Imagine this, right? March 10th, 2020. We're and Josh, you can relate to this on the fifth floor of the state capitol there. We're in the governor's tiny conference room here in Maryland on the second floor. It seats maybe 8 or 10 people. Governor, lieutenant governor, secretary of health, couple of lawyers, couple of industry leaders. March 10th, right? Small room, all unmasked, right? All unmasked, saying, the world is going to fall apart, and it, and what can we do now? It's we have photos of the meeting. It's really interesting to see how everything progressed. I think the most important date in my mind's eye was December 23rd, 2020. That was the date that Maryland got our first vaccines, and we prioritized Kapuna. We prioritized people, older Marylanders, not only in formalized settings, but in the community. And I am convinced that we saved lives with that prioritization. So having said that, I'd like to just hit a few points and make some connections on what each of you shared. I think what changed mostly for the good, which is really interesting, Josh, comparing again Maryland to Hawaii. In Hawaii you have Niihau and Kauai and Maui and Lanai and the Big Island, right? And so you have all these neighbor islands, and you have the capital island of Oahu. And so I would imagine that if you look pre-COVID, Hawaii had a higher uptake on telemedicine than did Maryland pre-pandemic. So Maryland has some of the preeminent healthcare institutions in the world, but you could measure our telemedicine visits in Maryland pre-pandemic in the hundreds of visits a month, hundreds, in a state of over 6 million people pre-COVID. And so one thing that has changed, that I think is a change for the good with a comma, is that telemedicine is out of the box. It's never going to be the same. We're always going to have a high uptake of telemedicine. Of course, the comma and the flip side to that, Josh, is what you mentioned in terms of things that you can't do over telemedicine, the screenings that went undone, the behavioral health issues, the impact, psychological impact of isolation. And so that was sort of the comma slash with telemedicine. Daryl, getting to what you said, I think you said communication and relationships. Did I get that right, Daryl, that you prioritize those? Well,
and transparency.
And transparency. Yeah, I think that trifecta of transparency, communication, and relationships, I pray never changes. It certainly was one of the secrets to success in Maryland to navigating the pandemic. I think a unique thing that as a nursing home guy, and a former government and AARP guy, I think one of the advantages we had in Maryland is that we have this unique contract with the federal government called the Maryland Total Cost of Care Contract, where we pay hospitals differently. And as a result of that, we all know one another. Like, I didn't struggle to phone the president or CEO of LifeBridge Health or the senior VP and CEO of University of Maryland, or the head of the hospital association. Or the head of the Docs Association. So I think we had a tremendous advantage of, we already had rapport, we had each other's cell phone numbers, we could communicate like that. I think that was a tremendous advantage. Now, it didn't come without challenges, like, who vaccinates first, and what about the second dose, and who's giving boosters, which I'm sure you all interacted. But I think relationships and care integration, we were reminded of the importance of that during the pandemic. And then unfortunately, we all knew, and probably several of the people that are watching and listening to us today knew, that workforce was an issue pre-pandemic, right? We knew that we didn't have enough physician training slots in the country. And so we weren't producing enough physicians. And we knew we didn't have enough nurse educator slots or lab time, so we weren't producing enough nurses. And we knew that we weren't necessarily hiring people that wanted to make healthcare a career as nurses, aides, or medical techs. And maybe in a full environment, full employment environment, maybe we had lost some of our focus on career ladders and growing people, right? So we all were aware pre-pandemic of these challenges, and workforce was a challenge pre-pandemic. And then what the pandemic did, as you say, Daryl, is it put this huge exclamation, yellow highlighter, screaming that it was a challenge. And here in Maryland, we have 40,000 medical techs, nurses, aides, LPNs, and RNs who in 2021 did not renew their licenses. 40,000 of them. That's a ridiculously high number, right? So some of the things that probably the 4 or 5 things, and I'll leave it at this and then ask any questions of you all, response from you all. Probably the biggest things that the pandemic shone a bright light on, and which we now, as you say, Daryl, healthcare is kind of on the ropes. We have to recognize it's on the ropes and deal with these things, are the workforce challenges, behavioral health. And let me just pause on behavioral health. During this most recent surge, the number one reason for emergency department boarders in Maryland, people who were in emergency departments for 24, 48 hours, who were eligible for a hospital bed, the vast majority of those folks were behavioral folks. And it was such a challenge. So workforce, behavioral health, social determinants of health, healthcare disparity, and then going forward, just calling it out so we can begin to work on it together. We will face the biggest pandemic on behavioral health and the impacts of isolation from school kids to above as a result of this pandemic. And we're going to need all of us, all hands on deck to work on it in the way that we did. Other than that, everything you said, we're very much in common with you all. So I'll pause there and go to you first, Josh. Any response or thoughts about what Daryl shared or what I just shared?
Yeah, I feel like we're in each other's minds there. I'll show my screen on my iPhone. So take a look. So if I can show this might be difficult. This is it basically scrolling through. These are the transparency changes that occurred for us. We had all of our main 14 hospitals texting me every morning with their numbers, how many people in the ICU and how many on ventilators. Something that they maybe never would have shared before. So everyone was in it together, and they knew that if they had an overflow in one facility, they would have to share the workload with others. I mean, it was incredible. So that's a great blessing now to see them all working together and realizing that we had no choice. So that was incredible. I would say to the question or the challenge of the healthcare shortage, the professional shortage, I'm more and more of the belief, and of course I'm biased because I was a National Health Corps guy, but I really think we should entertain the idea of national service going forward. It might be a way to unite. I'm instructed not to talk too much politics. I won't do it because I like everybody, frankly. But my point is this: national service works for some, and not mandatory national service, but national service to repay your debt, so that any nurse or social worker or doctor, any of us, and people can also be getting loan forgiveness in military service or other service, I think makes a lot of sense to consider going forward as we work on shortage disciplines. It might be teachers too, but I know we're going to need it for behavioral health workers. No question about that. Someone mentioned earlier about the ability to get better results with ethnicities. We saw that completely. When we do discharges and we have follow-up, say for our Samoan community, and they're followed by a Samoan member of the clan we saw that recurrence rates and rehospitalization rates dropped down. These were for our high utilizers that were utilizing the hospital constantly. They dropped down below the average of utilization for wealthy people that had every bit of access, as if they had someone from their extended family or community to help them. That was absolutely true. So there's so much truth in what you said. So I would go there. And then if I may talk about just a 30-second version of the health disparities question, the social determinants of health. I think that is so true. You put up a slide. I think Daryl put up a slide about lifespan dropping. Well, in Hawaii, where we have a homeless challenge, I did this talk once before on state of reform, where we have more people per capita that are homeless than any other place except for New York, because you can survive in Hawaii, and there are big health disparities and financial economic disparities. A person who is unsheltered homeless lives an average of 30 years less than an individual who has a home. 30 years. So for Hawaii, it's 81 years for average lifespan, down to 51 if you're homeless. So that is the ultimate increased mortality rate. I mean, that's the ultimate social determinant of health. And we've been housing people with small, like tiny houses. We immediately drop their drug consumption by 60% in the first month, and self-harm drops, their hospitalization use drops to nothing. And we assume, although we only have 2 years of data, that their lifespan is going to go back toward normal. So, I mean, all these things that you mentioned are just so true, and they were exacerbated, but
right.
We're seeing these truths now.
I bet their A1C and their diabetes stuff got massively improved as well. Daryl, there's a question here from Peter Jackson that Josh just answered. What can be done by policymakers, lawmakers to expand the healthcare workforce? Josh talks about national service. What there's talk about doing other things like loan repayment, tuition repayment. What are some of the things that you think we can do to expand the workforce in healthcare?
Sure. And real quick, I want to make one point just to follow up on Josh's, that, actually during this last surge, it got so bad in our state that we had a DOD team deployed to one of our hospitals. It was only 20 folks, nurses, RTs, and physicians. This is the hospital with 1,200 beds. So they made a small impact, but their impact on the teams and morale was enormous. And they were amazing. And they were here for 60 days. Then they went somewhere else and did the same thing. So national service, I love the idea. I will tell you, ironically, we've been having a lot of talks with local nursing schools specifically to understand how we can improve the pipeline. And you start understanding what the barriers that are there that you didn't even realize existed. And I would argue some of the first things that we can do, and we're trying to experiment with this now, is that. So believe it or not, even in spite of all the resignation of nurses, our local nursing schools, which are quite large, have said we have more demand still of students that want to be nurses than we have slots. So why don't you expand slots? Well, to expand slots, we need to be able to have enough preceptors. We often provide the preceptors in our hospitals and our clinics, and we can only accept so many because there are very specific rules around who can precept, where precepting happens, how much virtual simulation can be part of nursing education, and so forth. And this spans multiple different careers, nursing, respiratory therapy, so forth. So we're now working on innovative pathways to try to expand their curriculum and expand their slots, but that's going to require policy changes to be able to ensure that these are allowed through the state licensing agency and so forth. So you start realizing there's all these little barriers that didn't exist. And quite honestly, and Josh, I'm sure can attest, there was just a fascinating article I read on medical education of physicians. And, I'm actually what's called a cardiac electrophysiologist. So about as subspecialized as one can be, a very niche specialty. And you realize that the way medicine has evolved in the United States over so many years, there are state licensing boards that are all different and have different requirements. And there are specialty societies that often denote who can be in what specialty and limit slots, not to mention, as was mentioned, residency training slots that are limited. We have so many different limitations at every step. We actually have the longest medical education pathway in the developed world in spite of no better outcomes. We got rid of almost all of the combined undergrad and med school education that was truncated from 8 years to 6 years. I did 8 years of post-medical school training, which is way too much and ridiculous. That's why I'm so gray. So we need to change the systems in place. It might not require wholesale everything change. It might not require huge investment, but it requires change that's going to be hard because change is hard.
Yeah. And people are going to want to focus on excess safety. And there's going to be that tension between excess safety, proper education, and the need to be able to provide care. You make really, really good points there. Josh, what else would you add? I want to make sure I'm just really the connector. I want to make sure that each of you have a couple minutes. We're down to about 4 or 5 minutes left. So Josh, if you could just spend a couple minutes closing, and Daryl, I'm going to let you take us out.
So yes, and to clarify, yeah, I definitely think when I say about national service, that would be for loan forgiveness, right? For total debt forgiveness for anybody worked in these disciplines of need. And goodness knows we need it. We went from Medicaid population about 1 in 6 in our state to essentially about 1 in 3. It's almost where we are now after the COVID crisis, and that'll drop back down as people go back to work. I would say looking at behavioral health as primary care, essentially, I know that in a lot of states there's a carve out. We need to view things far more holistically, and behavioral health is primary care now. As you mentioned earlier, the hospital patients I'm seeing in the ER now, I'm seeing far more people with panic attacks, anxiety, depression than I am with COVID, seeing people with COVID, far more. So for what it's worth, in one ER, in one small corner of America. And I do think that it will have a revolutionary effect, COVID will, on us. You mentioned earlier, how will it change things and telehealth? Well, we went from about 1.5% of all of our providers being willing to do telehealth to 50%. So it just, we never change like that. That's, that's of course, that's more than a paradigm shift. That's a total revolution. So
right, that's revolutionary. Yeah.
So there's just so many things to do, and I couldn't agree more about all the social health considerations. I actually use the word social health. Everyone has different terms for these things, but I think they're mostly driven by trauma in my mind now. That seems to be the unifying theme based on what I've thought about these last few months and years. Whether you're traumatized because economically you're traumatized and you're wrestling with 3 jobs and 5 kids and it's so hard, or you're traumatized because you were in a state of self-harm, and you were traumatized by your addiction, and your brain was traumatized, and your family was traumatized, and you had socioeconomic drift to a disastrous place. All of these things are very real. And so we can reinvent the health system now because we've gone through a crisis where everyone realized once and for all, we actually are connected. You were connected. Somebody walking down the street could give you a life-threatening virus by just a touch or a cough. And so I hope that we learn those lessons, that we really are a country that can rely on one another and needs to know that we're connected for our solutions. And we're better than healthcare, where, when we're in a gown in an ER or a surgical facility or whatever, we're not worrying about whether or not we were a Biden person or a Trump person or a Hillary person or a Bernie person. We're worried about our daughter, or whether we're going to be here 12 years from now, or whether or not we're going to be able to afford our health care. So I think it laid bare many of the considerations. And for my part, I would love to see us unify on this as our national theme to get together and work together. And so I'm really grateful to you guys as experts in the field for what you do.
Outstanding. Daryl?
Yeah, I love it. And I'll be very brief, just following on Josh's comments. I recall vividly early in the pandemic, particularly, I think there were a lot of videos coming out of New York City when it was the hotspot, that people were applauding healthcare workers and heroes. And I recall kind of writing a little piece about this, just thinking to myself that, in prior wars, when our soldiers have gone to war, they were heroes and they are heroes. And that, my hope coming out of this was that those in healthcare that are really at the front lines trying to make everyone better, doing this altruistically, would be viewed as heroes. And after 2 long years, after divisiveness, workplace violence, behavioral health issues, so much, I fear that some of those viewpoints are lost. And I'm just hoping that regardless of all that, when I walk through the ERs or the ICUs, people are there to care and to do the right thing for people. And I hope we can get to a better place as a country. And I hope we can do good things for healthcare because we all need it.
Well, there's no doubt that each of you, and I know you're humble and you don't want to accept it, but there's no doubt that each of you are healthcare heroes, and your teams are healthcare heroes. And I'm blessed to be working amongst healthcare heroes. So all of you out there, Daryl at Spectrum Healthcare is not easy to track down. Please be in touch. Dr. Josh Green, the Lieutenant Governor of Hawaii, not hard to track down. Please be in touch. Know that we are all in service. Joe DeMatos here at the Health Facilities Association of Maryland. I'm at your service. Call, email anytime. It's going to take all of us to solve this going forward. So let's do it. Okay. Thank you all very, very much.